Hi, everybody. Happy holidays. My name is Nicole Lamberson. I was trained as a physician assistant and I volunteer doing outreach for the film Medicating Normal, and I host conversations like this one today. Thanks so much for joining us. We have a great guest today. Her name is Dejanee Neal, and she's a fourth-year pharmacy student. She worked as an extern with the Alliance for Benzodiazepine Best Practices, and she assisted there with a research project regarding the appropriate prescribing and deprescribing of benzodiazepines, and then published a research article of her own about the cognitive consequences of long-term benzodiazepine use. So welcome, Deja. Thanks for coming on today.
Of course. Thank you for having me.
Sure. So I guess just so that our audience and myself can get to know you a little bit better, you're still in school. How
Yeah.
many years of pharmacy school are total? Is it 4?
Yeah, so it's 4 years, and I have a couple months, so I'm done in May. So on the
Oh,
home
right.
stretch.
Getting close. All right.
Yes.
So why did you want to be a pharmacist in the first
Mhm.
place?
Yeah, so actually I found out about pharmacy. I used to play basketball in high school, and one of my coaches, his wife suggested that I look into pharmacy just because I was really interested in like sciences, helping people, because I was definitely one of those people who have the misconception that pharmacists just counted pills behind a counter. I was like, why are you even suggesting this to me? But after doing like some more research and all of the different I guess facets of pharmacy that were available. For one, I realized that I could help people, I could be involved in the sciences, and also that it's something I would never really get bored with, just because aside from the fact there's a whole bunch of different areas of pharmacy, things are always changing. And then another thing for me growing up, I had really bad eczema, like to the point where my doctor suggested putting me on chemo. And even as a kid, I was like, okay, that's a lot just for eczema. So I became really interested in like autoimmune and inflammatory diseases and realizing that, okay, now this is somewhere where I can actually help out. So that's kind of what brought me to pharmacy.
Wow. Okay. That's awesome. Yeah, I was reading your bio and I saw that you're interested in autoimmune disease. And I was like, okay, there's
Yeah.
going to be a story. You know,
Yes.
my passion for benzos and psychiatric
hmm
drugs was born of my own lived experience. So, yeah,
Yeah. And also to me, just seeing like other people's experiences as well. So it was like, okay, well, yeah, this is definitely an area where I can make a difference. So,
yeah. So, totally different from autoimmune disease. And also, I think you listed an interest in chemo, right? Or
yes,
oncology.
also, yeah.
Is psychiatric medications and
Mhm.
benzodiazepines specifically. So I'm wondering, like, why you even wanted to do an internship with the
hmm
Alliance for Best Practices. Like, were you
Yeah.
interested at all in benzos, or was this just like an opportunity in order to, I guess you probably need an externship or something for your schooling?
Yeah, so out of all honesty, at first I saw it as like a really good research opportunity. But like kind of within like because our internships or externships, they're planned like months in advance. So once it got a little bit closer, I did a lot of research in terms of like what they do, what I would be doing to help. And so for me, I don't know, maybe it's just because I'm a big dreamer. I like to have an impact on a really large scale. And for me, seeing like like I had no idea like the impact that benzodiazepines had on patients. Like even just reading your story, the long-term effects, just seeing that was really an area where I could help make a difference. Because like I really do think that like, community pharmacists, hospital pharmacists, they play a huge role. But for me, I wanted to be able to impact people, even honestly on like a worldwide scale. The more people I could help, the better. And also too, I'm really big on wanting to make positive change, seeing that this is something that we can educate like patients, providers on, just so that other people don't have to experience some things that, a lot of the patients where I've read stories about and things like that, so they don't have to experience the same thing. So I just feel like it was a really good opportunity for me to make a difference kind of like in the medical world.
Yeah, awesome. So what exactly was the research project that you did with the Alliance?
So the one that I assisted them with, it was a kind of about like the appropriate prescribing and deprescribing of benzodiazepines. So like just as we mentioned, like some of those long-term effects and how they impact people for the rest of their lives a lot of the time. just how benzodiazepines, for one, are typically used a lot longer than what they're recommended. Like even in my own research, seeing some patients that were on them for decades when a lot of guidelines only recommend them being used for like short term, like some less than 4 weeks, some even less than 2 weeks. And just bringing that to light that, hey, we really shouldn't be using these for that long, and it can be contributing to a lot of these adverse events that we're seeing. And then additionally so also, I guess I should say that it focused a lot on like mental health disorders like anxiety, insomnia, depression, things like that. And for those specific disease states, once again, going through the guidelines, seeing that they're not even really recommended for first line use. Because I think that's something where a lot of times they're jumped on for those disease states, but like we really should be trying other things first as well. And then also to just going into when should we be tapering, how should we be tapering, and really just finding out that there's not a lot of clear, concise evidence and guidelines out there. So really just trying to, I don't know, push the envelope and let people know that we really do need to be doing more research in this area so we can have those clear-cut guidelines on when we should be using them, how long, how to take, what to do, just so we can prevent a lot of those things from happening to patients.
Yeah. Okay. So it was basically like you guys just like dove into the literature to try to find
Yeah.
what is out there even.
Yeah.
Yeah.
So yeah, it was considered like a scoping review. So yeah, tons of articles were sifted through just to see, like you said, what's out there.
Okay, great. And then the end result was like a paper that reported on what you guys found.
Yeah, so that is actually still in the works of, being finalized, published, all of those things. So yeah, I'm definitely excited to see the end results of that come out so people can, benefit from all of the hard work that was done in terms of
Yeah,
that.
that's awesome. So when we get that, you'll have to share it with us so that we can, post it under this interview and people can
Mhm.
have access to it.
Yeah,
Um,
definitely.
yeah. And then after you did that, you went on and decided to write your own paper on the cognitive consequences of benzodiazepines. Is that
Mhm.
right?
Yeah, so I actually kind of worked on them simultaneously, which I think was really helpful just because for me to see, like, so in school we learned about some of those shorter term adverse effects, but doing some research on my own about like the long term effects, like what causes them, it kind of helped give me some more purpose and wanting to help with the other research and kind of understand like why they were even doing it in the first place. Um, so yeah, I just talked about like a lot of, mostly they were like in terms of the cognitive effects. So like in terms of like benzodiazepines kind of being like a CNS depressant, your brain kind of adapts to that and gets used to it. So when patients come off of it, they have a lot of like the processing issues in terms of like the slower processing time, maybe not even being able to feel like they're thinking as well as they used to, even in terms of things like spatial awareness, like motor function, like all of those things that can impact. And something I found that was really important was just because like I mentioned, they can be used to treat things like anxiety, depression, things like that. And I think there's like one of the reasons people don't pay as much attention to is because like those disease states in themselves can cause some of those cognitive issues, like some fogginess. Sometimes patients are not really wanting to do too much. So when patients come off of those medications, a lot of times those are attributed to the disease state rather than the medication. So I felt like that was something really important to, make more widely known so that, hey, maybe we should be paying attention to the impacts of the medications as well, because it really is, causing these adverse events that we're talking about.
Mhm. And you reported in the paper that you wrote that I guess it was something like, I can't remember how many months, but it was many, many months later that the
Yeah.
patients post cessation were still having cognitive deficits. And so
Yeah. So
it
yeah, like
really,
sometimes it's like you said for months, sometimes patients can like have trouble like even coming off of the medications at all. And sometimes they may not ever go away because there is, so like it is one of those things that we need to learn more about, because sometimes, over time it can get better, but there's some patients where it may not get, or it'll get better, but it may not return to baseline.
yeah. I wonder, like when I read those, like how far are we following people? Because I'm
Yeah.
off benzos for over 11 years and I
Hmm.
definitely still have
Wow.
symptoms from a
Hmm.
projected injury,
Yeah.
I think medicine will look at somebody like me and say, no way that can have anything to do with
Yeah.
that was 11 years ago, or if somebody was following me, they might declare that this is permanent, that um,
Hmm.
it's never going to go away. And that's to be told, I don't know. 2 years
Yeah.
ago, I could feel like even more healed than I am
Mhm.
now. So it's like, I just wonder what the timeline is of these. I know they're not following people for expecting them to go on,
Mm.
for 15 years or something and still have deficits and see what happens. But we need
Yeah.
to be.
Yeah, definitely. Because even just like looking for articles, like for my research, there really wasn't as much out there as you would think. So, like, once again, that's another reason why we're trying to push to be like, okay, we need to do more research in this area because there's so much that we don't know and it can really make a big difference.
Yeah, exactly. And that paper you wrote was in Pharmacy Times, right? Is
Yes,
where it was
correct.
posted. Okay, so we'll put a link to it for anybody who wants to read, um, and share that if you want to. I'm wondering if you
Okay.
got any feedback from writing that from colleagues, or did anyone, have anything to say about?
Yeah. So actually I worked with my preceptor for the rotation. Her name is Jolene Bressy. She was super amazing. So yeah, she was definitely like the person that I bounced ideas off of. And obviously, her having a lot more experience in this area than I do. She was the one that gave me a lot of feedback. And even like prior to like putting it out, just talking to me about the things that I should really like try to focus on, what things are important or how I'm presenting the information. So she was definitely a really good um set of eyes to bounce ideas off. Like I mentioned, she gave me some great guidance. So yeah, that's kind of how that got to where it was. And she was the one that sent it to Pharmacy Times for them to look at.
Oh, nice. And then they just accepted it and published it. That's
Yep, they
good.
did.
And do you know what the readership is like at Pharmacy Times? Is it pretty well, like a
Um,
popular? Okay.
so I'm not completely sure. I might be a little bit have a biased perception just because like my friends are pharmacy students, being around a lot of other pharmacists, so I know it's well read within that community, but I'm honestly not really sure in terms of like patients how much they like pay attention or read those things. Like I know my family does just because I told them about it, but yeah, I'm
Mhm.
not really sure outside of like actual medical professionals what the viewership is like. But I feel like, for me, like I've kind of always known about the publication. I don't know if that's just because like that's what I was interested in, but to me it seems like it probably has pretty good viewership.
Okay, great. So maybe educated some folks about benzos who didn't know some of the
Yeah.
things you found. What about when you were researching for that piece, did you find about the dementia Alzheimer's link between benzos? Because it seems like everything I read is like
Mhm.
half the people say absolutely, and the other half say there's no link. And it's like, well, they both can't be true at the same
Yeah.
time. So
So
what did
that's
you discover?
That's the same thing that I found as well. So I kind of talked about both sides, like kind of similarly to how like some people still don't think that benzodiazepines have any like link to those like other cognitive consequences also too, just because of like the disease states that are managed and some things like that. So it definitely was 50-50 in terms of like some people going for it and agreeing, some people not. And once again, like all of this just goes to show that we need more research because like you said, you can't be both. So yeah, it was definitely a two-sided kind of argument going on. So yeah, I tried to kind of present both sides and talk about why people felt each way in
Mhm.
the article without, being too long about it.
Yeah. And then what about like when you were looking around, what did you find about for who was most at risk for cognitive consequences? Were there
Mhm.
like some groups or some benzos specifically that were more risky than others?
Yeah. So in terms of like some of the more solid things that I found, it looks like, obviously like the longer patients used it, then they were more at risk. Um, and then like higher doses, and sometimes like I found like that the shorter acting benzodiazepines caused like an increased risk because like a lot of times when we talk about tapering, we talk about switching to those longer term ones. So it looks like patients that are on like the short acting medications have a higher risk. Um, but then, like, interestingly enough, I found some articles that said men were at higher risk, and then some that found that women were at higher risk. So, once again, another one of
Nobody
those
knows.
decided,
Yeah.
yes. So, once again, an area for more research, which just seems to be the commonality between everything.
Yeah. Yeah. Okay. Um, so one of the reasons I wanted to have you on was because you're still in school. And
Mhm.
so I think that's like an important group to tap into to sort of learn about like, all right, I mean, obviously I'm not trying to like disparage your school or anything
Mhm.
like that, but I went to PA school
Yeah.
and I didn't have any education whatsoever on
Mhm.
uh, benzodiazepines, like as far as the risks and harms, and especially
Yeah.
prescribing. I mean, it was very quickly presented to us that, like, oh, they could cause seizures if you stop them abruptly, but it was more under like the addiction lens of
Yeah.
like, it wasn't like, oh, if a doctor is prescribing these to a patient and they're taking them exactly as prescribed, like the doctor
Mhm.
tells them, and
Yeah.
the doctor doesn't tell them, oh, hey, by the way, you're not actually supposed to be on these for more than like 2 weeks or something, and the
Yeah.
doctor keeps refilling the prescription, then the patient's going to develop this physiological dependence, and then withdrawal is like this, multi-year, at
Yeah.
best process of slowly peeling the dose away.
Mhm.
What kind of education in your school did you get around those kinds of things in pharmacy training?
Yeah, so a lot of what we talked about, so one thing I will say that was good is that there was like the differentiation between like dependence and addiction.
Yeah.
Just because obviously, those are two different things, like using like specific language just to make sure that, think also too, like with been speaking to patients, letting them know that like this isn't necessarily your fault, like in terms of, like a physical dependence issue. And then even like, some of the risk factors that I just mentioned in terms of like who's more likely to develop them. So then we can keep an eye on those patients or maybe make changes to their regimen so they don't get to that point where it develops.
Mhm.
Um, and then even like the withdrawal syndromes, like you mentioned, like the seizures, just some of the other things like, the sweating, tremors, like tachycardia, hypertension, all of those things. Um, and then like we also did talk about like, a tapering regimen and things like that. But I think it's tough because since, as I just mentioned, there's really no concise guidelines on what to do. We talk about, okay, you should taper it, but not necessarily like how we should taper it. Like, what is there like a best way to do it based on how long a patient has been on the medication?
Mhm.
Like we briefly did talk about, okay, decrease the dose a little bit. If you notice that the patient has symptoms, stop there. You may have to increase, then go back down. But it's like, okay, well, how much do we decrease or increase?
Yeah.
And then another thing that I think was missing, not necessarily on the part of like my school. Once again, there's not a lot in terms of like those long-term like effects of, what's happening, just because like you said, it is like a two-sided thing. Some people think it doesn't even exist. And then on the other side, we're like, hey, this is really a problem. So I think it's hard for schools to teach that if there's really not, once again, like really specific guidelines. So that's kind of where we're at. And I think my school is also really good at teaching us that this is what we're giving you. It's kind of like a baseline, but they also give us the skills to like look for the updated guidelines, stay up to date on like clinical trials and things like that. And then even on like our rotations, I think that's really helpful because in real world practice, we get to see what's happening. So like it was interesting for me to, have my rotation with the Alliance first, and then I moved on to like community hospitals, things like that. So then I really got to see like what's being talked about. So I think it's really helpful to at least have that real life experience so it can at least put it in our minds that, hey, this is something we need to pay attention to and do further research.
Mhm. Yeah. And what about other psychiatric drugs like antidepressants? Do you think you got the same sort of education about like these can cause physical dependence and withdrawal syndromes as well? They're very
Um,
similar. Yeah.
so honestly, not. That is actually something that I'm still like really interested in learning more about because once again, we talk about like, hey, here's the side effects that can happen right now, but not really things that can happen down the line. Like maybe with like certain like antipsychotic medications, if I recall, maybe we talked about it briefly. But other than that, honestly, not really. I really don't remember. Like I remember hearing like the withdrawal syndrome or withdrawal syndrome and symptoms like within that short term, but really not some of those long-term effects. Especially too because I think it's more common to hear that patients are on those medications specifically like for a lifetime. So I think maybe it's like if they're not going to stop, then why even pay attention to this? I know that sounds bad, but maybe that's like the thinking behind it.
Yeah. Yeah. I think it's just kind of lesser known, I hear a
Yeah.
lot of even people that I work with who are really educated medical professionals in
Hmm.
the benzodiazepine space. So they're
Yeah.
allies, they're educating about benzos and some of the harms. And then I hear them say in their presentation, instead of benzos, like a good first line alternative is an SSRI antidepressant. And I'm like,
Mhm.
wait a minute, hold on. Like, if we're not going to be telling the patient that they can become physically dependent to those as well and have a withdrawal syndrome that can go on for years and be equally as
Yeah.
devastating, we're just changing the direction of harm that we're
Yeah.
doing, and not giving those patients informed consent either.
Yeah, because
So,
that's what we're taught as well, to go like the SSRI route or SNR, things like that. So like, yeah, I think it's really interesting and important that you mentioned that, because like even like I didn't really know about those things.
yeah, yeah. What about in school? How are you trained to educate patients? So, like,
Mhm.
I come in and I have a benzo prescription. And I mean, what do you, as the pharmacist, what is your role as in education or giving me informed consent?
Mhm.
I was curious, like, okay, there's the doctor, and then,
Yeah.
you go to the pharmacy to pick it up. So there's
Mhm.
two places where you could have
Yeah.
impact in education, and I'm wondering what your role is.
Yeah, so we do like these mock counseling sessions. So in an ideal world, we would like to have like anywhere from 10 to 15 minutes with patients. And then we typically start by going over like, what is it being used for, just to make sure that the indication itself is even appropriate. Like going through all of their other medications, checking for interactions. So like for example, if a patient is on an opioid, letting them know that, hey, this is something you need to look out for like the increased risk of like the CNS and respiratory depression. Going over those things, because of course like the medication interactions are important. And then even just going into what to expect, how long it may take to work, what's the appropriate dose. And then even going into like, these are the side effects that you may experience. Once again, don't just stop the medication. Depending on how long. Sometimes people have like the one dose before a procedure. Obviously, that's different than like if patients are going to be on it for weeks, then talking to them. But a lot of times it's refer back to your doctor just to see like how they want you to taper off of it, whether they want you to continue, but at least letting them be aware, like don't just stop the medication.
Mhm.
Um, and then even in terms of like things like that they should be looking at, like the main things that they should look out for that should prompt them to like seek medical attention, like whether it is like that respiratory depression that I mentioned to you, or just other things that they should follow up with their doctor, just because like maybe this is not the best medication for you. um but a lot of times it doesn't really include that long term um type of risk thing, but I do think it's at least important in the short term that we can let patients to know like what to look out for. And then also too, a lot of times what I've noticed, like in the real world, patients have no idea that these things can happen. So even just letting them know what they're getting into so they can make a decision on whether or not they want to move forward with treatment or not.
Yeah, exactly. I mean, that bit is so important. I think just
Mhm.
like, hey, you might not be aware of this, especially now since benzos have the updated black box warning that has all
Yeah.
that information. Like,
Mhm.
part of the problem with it is that it's buried in the literature
Yeah.
and, you know, guilty here. I've like not opened the thing that's as big as my bedspread and like read the tiny
Yeah.
little print. So somebody needs to, warn patients and correct me if I'm wrong, but like if there's a black box warning at the pharmacy, there isn't like a bright yellow sticker on the bottle or like something to alert the
Mhm.
patient. They have to find the boxed warning in the paperwork,
Yeah.
right? Yeah.
Yes. So sometimes like, and also too, like there are those information packets that are sometimes stapled to it, but I feel like patients kind of see that as like the fine print when they're signing up for like, an app or something like that. And they honestly probably don't read it. And so like we try as hard as we can to like catch some of those things, but I think also too, just in the world of community pharmacy, like I don't think I've ever seen like that ideal 10 to 15-minute interaction like I mentioned either. So it's really hard to disseminate that information. Then even if it is like a big box, it's like it's a big black box literally. So it just blends in with everything else as well. So patients probably once again don't pay attention to it.
Yeah, I think that's the reality. I mean, when you were telling me, what you're taught in school, 10 minutes,
Hmm.
you get to explain all this, but like I've been to the pharmacy even
Hmm.
recently for like, an antibiotic or something. And
Yeah.
I think because of the pace of, there's a huge line and these people are stressed and they're busy and
Yeah.
the pharmacists now they're giving COVID and flu shots, like that's part of their
Mhm.
job. And so they're just like running all over the place. And I don't think
Yeah.
people are getting counseling for much at all. It's like you just
Mhm.
sign the little thing with your finger, and it probably says somewhere above it, like,
Yeah.
all my questions have been answered or
Mhm.
whatever. And so it's just kind
Yeah.
of like a gap, like a place where we could be catching patients, but
Mhm.
it's like the reality of the way things are, same as medical practice. I mean, the
Mhm.
doctor should be able to sit down and go over all these things with you, but he has what, 7 minutes or something before he has to flit off to the next patient. And so
Yeah.
I think with, benzos and psychiatric drugs is kind of where the informed consent is getting lost.
Yeah, definitely. And like especially considering that like benzos are one of the most commonly prescribed medications, you would think that we paid a lot more attention to it anyway. And like you said, like it's a multi-faceted problem. Like all of the in terms of like the metrics, all the pressure that's put on pharmacists, and also to like I think that the question, like you said, a lot of times people are told, "Okay, can you just sign this, like, for your prescription?" But they don't know that, like, they're kind of waiving their right to counseling, or sometimes at every interaction, like, we would ask, "Do you have any questions for the pharmacist?" But patients don't know what they don't know, and a lot of times it's like, "Okay, if my doctor is prescribing this medication, then it must be safe, or the benefit must outweigh the risk." But I think it just kind of sucks because we're putting a lot on the patient. Like I said, they don't know what they don't know. And when I have had the opportunity, like in certain community settings, to actually counsel patients on certain things, they were like amazed. Even if they had been on the medication for a while, it's like, okay, I didn't know that this could happen, or that makes sense, or I'm glad you talked to me about that. Or even like at times, like, okay, well, can we contact my doctor for an alternative? So, like, I don't think that we realize, or even patients realize, like, how much of a difference that can make, but also too, like, going to show that, okay, if these are the couple times that we did have the time to interact with the patient the way that we wanted to. So imagine if we did this, like, with every patient, all of the changes that could be made.
Yeah, exactly. Yeah, there's so many places where kind of the ball gets dropped and it's just down
Mhm.
to time and pressure and,
Yeah.
everything else. Do you think, I mean, I know you did, I won't name the pharmacy because I don't want to, point any one specific one out, but like a major chain pharmacy
Mhm.
versus like a mom and pop. Do you think there's a benefit to kind of going to one of the smaller ones if you want more
Yeah.
care and attention? Yeah.
I definitely think there is, because they probably would have more time to actually sit down and go through things with patients. Um, because well, also too, so like I obviously like where I was for that rotation, but I also did another one with another major chain pharmacy, but it was in an area where there were still a lot of scripts that were filled every day, but, like, things were more organized. There was never that rush when there were, like, 50 people trying to get their prescription. So, like, that's where, like, the area where I was talking to you about in terms of, like, having more time to really sit down with people. Um, so yeah, because a lot of times, like, when things go up to corporate, sometimes, like, the people telling the pharmacist what to do may not even be pharmacists or medical professionals. So all they see is the number. So I think, like, yeah, going to that smaller place where there is more time, a lot of times they may know everybody by name that comes to their pharmacy. Like they probably remember you. They remember what disease that you're being treated for. Sometimes they remember what medications you're picking up. So then they really have that time to focus on you and go through everything in detail just to make sure that nothing is missed.
Yeah. Okay. That's a good tip. I mean, I think the take home message from my own experience that I
Mhm.
try to impart on people all the time is it's really unfortunate, but it's
Yeah.
reality. And sometimes that's life, right? There's unfortunate
Mhm.
things that we have to accept are reality. And it's that
Mhm.
you have to be your own best health advocate. You
Yeah.
probably are going to have to do a ton of research on medications yourself.
Mhm.
And then also maybe you're going to have to demand informed consent. Instead of just signing the box, you might have to say, like, I need somebody to sit down with me and go
Yeah.
over, and just ask instead of just
Mhm.
everybody just signs away, and
Yeah.
doesn't know what they're doing or taking.
Yeah, because some even simple things like antibiotics, like people not even realizing that like those things have certain risks to them. So
Oh,
yeah, I
yeah.
just think that's really important just for these patients to know what to kind of look out for. And another thing, like too, I will say that like I notice a lot of patients coming in more saying, like, "My doctor sat down and talked to me about this." So, like, I think that's also really helpful too, like, them being able to at least set the baseline. Like, I didn't realize because, like, it's like you said, a lot of times in my doctor's appointments, there's never really that time. So I think, like, when they can at least get that baseline, it's really great. So then they can come to us and ask further questions. So I think, kudos to the doctors that do have the time and who are able to do that as well.
Yeah, exactly. And it's a systemic, it's a
Yeah.
problem with the way that medical care is set up.
Mhm.
Um,
Yeah.
I don't know if they do it better in other countries, probably in some places, and maybe just as bad as the US in others, but there's
Yeah.
definitely huge room for improvement.
Yeah.
That's another part I was thinking about, like you're talking about, it's obviously like a kind of a team effort. The doctor sees the patient, they write a prescription, the pharmacist fills it and has
Mhm.
more opportunity for education. But I've seen, as with anything, there's like good and
Yeah.
bad. Um, and you have to sort of like weigh one or the other. So I've seen pharmacists now, probably
Mhm.
because of the boxed warning and
Yeah.
all the problems that are emerging with benzos, that like the education is getting out there. And the pharmacist will actually, because I work with a psychiatrist who helps
Mhm.
people come off of benzos and other psych
Mhm.
meds. And he tells me all the time, like, man, some of these pharmacists are just like, giving me a hell of a time to get
Mhm.
these prescriptions, which it's like, okay, on one hand, that's good because they're recognizing, like, hey, man, you don't want to be writing long-term prescriptions for benzos,
Mhm.
but he's writing them so that the patient can withdraw. So I see
Mhm.
this gap in knowledge of sometimes the pharmacists like think they're doing a good thing by
Mhm.
asking
Yeah.
tough questions and pushing back, but they need to be educated on, like, all right, for example, if a script comes in for a patient who's on short-acting Xanax, but
Mhm.
he's crossing over to long-acting Valium in order to taper,
Yeah.
the pharmacists are like, "What are you doing? You're giving 2 benzos, Valium and the alarm
Mhm.
bells go off because they don't know that that's they
Yeah.
don't know. So, um, yeah, I guess on that note, I kind of want to ask, like, what rights do pharmacists have to kind of like refuse a prescription or
Mhm.
push back on a doctor who is,
Yeah.
say, they're not doing the deprescribing, but they're
Mhm.
prescribing recklessly,
Yeah.
big doses for a long period of time. Like, can you call up the doctor? Can you like what can you do as a
Mhm.
pharmacist?
Yeah,
Yeah.
so pretty much like anytime if there's an unknown, also too, probably the anxiety that comes with the risk of like losing your license. It's like, okay, this could be reasonable, but I'm really not sure. So like anytime there is that, then the pharmacist pretty much has to, if it's not, if it doesn't seem like reasonable, then there's that right to not fill the prescription, contact the doctor. And I think it would be really helpful once again, this issue of like the shared medical record, because like as you say, like if this is just like the original treatment plan for whatever the disease state is, then like you said, those 2 benzos, that seems insane. And it's a lot of times that's probably what we're thinking, but like then it's okay, it makes a lot more sense if you're switching, and that's why. Cause like even a lot of times, like when I was on my rotation with like SSRIs, it's like, okay, I see you have 150 milligrams of sertraline, and then I also see you have 100. Are you taking them at the same time? That doesn't make too much sense right now. So, we're gonna flag it, call the doctor, but like then it's like, okay, they're tapering down. So it's like, it's just kind of tough because in the community pharmacy, you have to put the puzzle pieces together. You just see the medications. Sometimes you see the other medications, so maybe you can get an idea of what's being treated. A lot of times we may not even know the disease state unless the patient tells us. So it's just really hard. It's kind of a guessing game, and it's one of those things where we'd rather be safe than sorry and ask those questions.
Mhm.
Which I know probably irritates the doctors because like I just sat down with this patient, I just did all of this work. But yeah, that's kind of where it comes from, that we really have no idea. So that's why I think it'd be great to have a shared medical record, because then we can at least put 2 and 2 together, like see the doctor's notes, and it's like, okay, if this makes sense, and that would probably save so much time, so many interactions. So I think that would be great if that was something that existed.
Yeah, I know, and it's like Europe where they have universal health care. I think they do have a
Hmm.
shared medical record, which
Yeah.
for patient interaction and knowing what's going on, that's huge. Of course, there's downsides to it too.
Yeah.
If you get pinned with a psychiatric diagnosis for benzo withdrawal that was
Mhm.
misdiagnosed. Now, every
Yeah.
doctor you encounter going
Mhm.
forward thinks you're a mental patient because one person
Yeah.
put your chart, so it's like positives and negatives,
Mhm.
absolutely. But yeah, I imagine on your side as the pharmacist, you just get this prescription for even if it's like multiple different doses, and
Yeah.
they're like, why is this, happening? And then if they're not educated in school
Mhm.
about the need for tapering and that they need all these different sizes and oh, now you get like a
Yeah.
giant bottle of Xanax liquid, in addition to, and so I can see, why they kind of freak out, but yeah.
Yeah. And I think that's also another area where it is helpful when like even if it's not like a super long session when doctors can really educate at least on like this is what we're doing, this is why we're doing it like to the patients because it does save a lot of times when patients are well aware of what's going on and they can tell us, okay, this is why this looks a little funny, this is what my doctor's doing, this is the plan. So at least this gives us an idea and sometimes saves us the headache of having to call the doctor because then it's like, okay, now this makes sense.
Yeah, I mean, for patients too who are in this tapering, I'll call it a nightmare for some of them, but
Mhm.
caught in this cobweb of having to come
Yeah.
off of these psychiatric drugs. If there, I mean, is there anything they can tell their doctor to sort of write on the script that makes it easier? Like, can you write like for taper, so that the
Mhm.
pharmacist is aware that the person is tapering?
Mm. Honestly, I think that
Verbalize
that
it
would be
to them?
yeah, like, I
Yeah.
think that would honestly be a really good idea, especially because, like, if they are tapering, then it's probably one of those things where it's like, "Okay, take this dose for, like, however long, then go to this dose," like, and so
Mhm.
on and so forth. So, honestly, like you said, just writing for tapering would probably be a really good idea, I think.
Yeah. Okay. Great. Um, and so my last question for you is one, just being an African American, I'm wondering if you have any insight into, I've been around in the withdrawal communities for
Mhm.
like 14 years of people on
Mhm.
psychiatric meds and going through this. And one thing I noticed is there's like not a lot of people of color in the groups.
Mhm.
And so what do you think, like, as far as your research or just
Yeah.
interacting with patients in your training? Why is it mainly like a white person problem, especially white women,
Yeah.
with these benzos and psychiatric medications?
So I think this is another like multifaceted issue that we could probably go on talking about forever.
Yeah.
But I think so one of them probably doesn't just apply to like Black patients is like the difference between like addiction and physical dependence.
Mhm.
And if patients don't know that, then I feel like they automatically go to like the addiction route, feeling like they constantly need it, not realizing what's really causing it. So I think that can lead to some shame. And then a lot of times, I think just within the Black community, possibly just because of like some distrust of like doctors being scared of going to the doctor, things like that. I think there is that fear of reaching out for help sometimes, also too, because I think it makes a problem more real. So I think there is a lot of that fear. And then even just like there's this big thing of people wanting to do things themselves. Um, and I don't know, it's a lot. Also not realizing, probably not realizing that there are those support groups out there. And then even so, like you said, a lot of times it's like white women. So like on the Black male side, I think it's one of those things where even possibly like with white males, like there's a thing of like, you're supposed to be like a strong masculine figure. So I think sometimes, especially like people that have like families that look up to them, kids, I think sometimes it can come off as weak if you're struggling like with this type of issue if you need help for it. But I think just a lot of it is just trying to like correct the misconceptions and let patients know what's really going on, that it's not your fault. The same way that you treat another medical problem, like this is essentially that where like you can go and get help for it. If we kind of get rid of some of those like stereotypes, then I think that could definitely help the issue as well. And I think another thing that probably contributes to the issue in terms of like the addiction versus dependence is that like unfortunately like sometimes these drugs are used recreationally, kind of like the same way that like opioids are used recreationally, but a lot of patients that are prescribed them, they have that same physical dependence. So I think all they probably know from like, culture wise, like media wise, is like, okay, this is a drug that people use for fun and this is what happens. So maybe that's how I ended up. So I think out of many issues, I think that's just kind of like some of the things that go through people's heads in terms of like not even one, knowing that they can go get help, and two, like kind of being fearful of going to get help just because of how people may view them.
Yeah. Yeah. There was a black guy that I supported in benzo withdrawal, and I asked him the same
Hmm.
question. And he, I was like, you're like the only black guy I've seen in
Hmm.
14 years. Like, and he said
Yeah.
basically the same thing as you, as that it's really sort of stigmatized in the Black community, especially to be a
Hmm.
man and to be
Yeah.
taking psychiatric meds or to need help or
Hmm.
anything like that. So I think it's just and also he mentioned the distrust of the medical community and that
Hmm.
kind of thing as well.
Yeah.
And I think too that just historically, like the way women are viewed as like hysterical. And like if you look
Yeah.
back at the advertisements for benzodiazepines, and it was like, mother's little helper, like give it to your
Hmm.
hysterical wife because we dare to have emotions,
Yeah.
that men, don't maybe necessarily experience in the same way or whatever. But
Yeah.
yeah, I mean, it's a loaded topic that you could probably pick apart
Yes, for
for
sure.
hours. All the cultural, I'm sure, it'd be interesting to talk to like Asians too and see what their views are on,
Yeah.
taking
Yeah, I definitely
psychiatric
agree.
medications and all of that. But yeah, so interesting. I just wanted your perspective if you had seen that sort of working or doing your internships of like this big difference in like who's filling the prescriptions for psychiatric medications.
Yeah, I definitely do like I've never paid attention to that in terms of who's filling, but yeah, it's like you said, it's typically mostly like white females. And then if I do see black patients, it's typically black females as well. So
Mhm.
yeah, I don't think there's only one patient that I could remember like even feeling like a benzo, like a black male, but I think based on like the dosing and everything, I think it was possibly for like a seizure disorder. Um, I'm not really sure, but like that's kind of what it seemed like. But yeah, in terms of like the mental health, you really don't see like males in general, and especially not black males.
Yeah. Yeah. And you talked about the physical dependence
Hmm.
addiction bit. I mean, that for me is huge. We've done so much advocacy around it, that
Hmm.
one piece, because I remember going to bed every night and taking my benzo,
Hmm.
and obviously I knew that there was addiction potential. That's what it
Yeah.
says in the pamphlet, and that's what I was trained in PA school.
Hmm.
But everybody's idea of addiction is, the crackhead on the street or
Yeah, and that
somebody.
it's your fault.
Yeah. And so I took it every night and swallowed it with the false, safe sense of security that
Hmm.
I'm not addicted to anything. My
Yeah.
doctor told me to take this. So if we're not explaining in great detail the two
Hmm.
differences between those terms and what they mean,
Yeah.
implications for the patient, it's just going to keep happening over and over and over again.
Yeah. I definitely agree. And I also think too, another thing is like, how are we disseminating? Like, obviously, there's like the continued education for like healthcare professionals, but like, it's only a certain amount of hours that are required. And they're probably focusing on like some of the big areas like within which they practice. And I think it can also be hard. So, like, if a patient finally does like, work up the courage to say, hey, I need help with this, I think this is an issue. Unfortunately, if they do get the doctor on the first time that doesn't know that this is like a physical dependence issue, or knowing that it can cause those long-term things, and like they're like, okay, I don't really think that's a problem. A lot of times patients don't know that, okay, maybe I should shop around and get some different opinions first. It's like you said, they have to be their best advocate. And I just think it kind of sucks because like you said, like that information isn't wide known to everyone. So you may get different answers from different people. So then it's probably another thing where if they get turned down or like told that it's not really an issue, once again, it kind of goes into this thing where they feel ashamed because a lot of times they may feel like it's their fault and like, how did I get here? I didn't think this was going to happen to me. Like you said, I was taking it as directed, all of those things.
Yeah. I mean, I try to tell people all the time, like, this is an adverse drug reaction. It's
Yeah.
an accident. It's not a moral failing or,
Hmm.
but yeah, people do beat themselves up constantly and say, like, I should have known,
Hmm.
and it's like, you should have been educated
Yeah.
by people who were prescribing you this. And if they didn't know, how could you possibly have
Yeah,
known,
exactly.
you know? Yeah. So overall, we just have to do better. You mentioned in your bio having an interest in oncology. I don't know how, like, what part you'll work in, but that's another place we see people all the time injured by benzos because they get cancer
Mhm.
and they have to go through chemo and the adverse effects of chemo. They might have anxiety
Yeah.
as an adverse drug effect, or just the fact that you have cancer is like anxiety
Yeah.
provoking. And then the cancer, if they're lucky, goes into remission, they get better and they try to get back to their life. And they're like, oh, well, you don't need that anti or benzodiazepine anymore. Maybe the oncologist stops prescribing it. We've had that happen.
Mhm.
And then they show up in our groups and they'll say, this is worse than the cancer that I had, like the suffering from trying to get off of this benzo is worse than the chemotherapy that I had to have for 6 months
Mhm.
or whatever it was. So we just like taken somebody in this horrible health crisis and then
Yeah.
giving them like a
Another one.
devastating new illness that they have to
Yeah.
spend 2 or 3 more years or more of their lives trying to get over. It's
Yeah.
really, really sad.
Yeah, and I think it's just so hard because like you really don't have those other short acting medications for like anxiety and other things because like other things like, like the SSRIs, which like you mentioned have their problems of their own. It's typically okay, you have to wait like a month or two for them to work. And sometimes when things are really bad, like or if it's just for like acute episodes of things like patients may not have that long to wait or like, may not be comfortable with waiting that long because it really can be debilitating going through some of those things. So I think
Yeah.
when they're needed, I mean, the part is, I mean, the benzodiazepines do work, but it's just really finding that balance between once you get kind of over that edge of causing some of those adverse things, and it's like, then it feels like, was it really worth it? Like, what else should we have done? Like, just things like that. But it's like you said, it's one storm into another.
Yeah. Yeah. And I think if patients knew the risk, it's like, all right, well, maybe,
Hmm.
it really sucks to have to deal with anxiety. But if I know that this potential for physical dependence and withdrawal is down the pipe, like, what if I could sort of space the benzo out and only take it like twice a week or once a week and just use it very sparingly or something to sort
Hmm.
of get myself through this health crisis or whatever the crisis
Yeah.
is? And then spare yourself, the
Hmm.
physical dependence and withdrawal syndrome later.
Yeah. And that's why
Yeah.
I think it's really important to like have like just being even if it's like non-farm stuff, a lot of times like just because like I myself have had like issues in terms of anxiety. So like a lot of times like people will say, well, yeah, you have to find those other things and techniques that can calm you down, but they leave it at that. And obviously like I would know how to look up and go find those things, but most patients wouldn't know. So it's like, okay, well, now I'm
Yeah.
stuck. I have to go find something else. So like even just finding like even if patients do have like access to therapists or like just other ways to try to manage some of those things, just really trying to come at it from all angles, whether it's anxiety or something else. So like just really trying to minimize the need for those
Yeah.
specific medications.
Yeah. There's a doctor, Peter Gocha is his name. I don't know if you've come across him at all, but he's brilliant. And he was co-founder of the Cochrane collaboration, which is really
Mhm.
highly respected in medicine. But he
Yeah.
said at a lecture, actually, that he was giving to doctors, one of the physicians in the crowd asked him, like, what is your main message to
Hmm.
physicians? And he was like, use medicines very sparingly, like they're rarely
Hmm.
ever necessary.
Hmm.
So I think if we all kind of came from that spot, like in the beginning, is this really
Yeah.
necessary, or how can we use it like in the most sparing way?
Hmm.
We'd be far better off as a population.
Yeah. Thankfully, I've had some really good professors who have been like, I'm a pharmacist, but a lot of times my goal is to get you off the medications and not keep adding more and more. And I
Mhm.
think like it just sucks because especially like when you're in the midst of going through something really bad, like you want the quick fix, whether it's like mental health or like other things like cardiovascular disease, like things like that. And I think it's just hard because, like, especially in America, we're in that fast pace, like microwave culture, as people like to call it sometimes. And like a lot of
Yeah.
times, the things that don't require medication, they can be harder. Sometimes they require discipline and time consuming things like that. So I think it's just hard, especially when people want relief like now.
Yeah. Yeah, it's true. But what I will say is this, all of the things that I should have tried that were non medical interventions for having anxiety, I had to use when I
Mhm.
was coming off of benzos because the anxiety was 10,000
Wow.
times worse than the
Mhm.
pre-existing anxiety. And so I was
Wow.
forced into yoga, breathing exercises, meditation, walking,
Wow.
like, and I, obviously in hindsight, like if I would have done
Mhm.
those things, I probably never would have taken benzodiazepines in the first place.
But yeah,
So,
once again, it's like if only you had known, or like
yeah,
who knows if the person that, prescribed them even knew that, that was
yeah.
a risk. So it's just, I think it's just hard because like we said, we want everybody to be educated on it, but like I think it's like there's only so much space in a person's brain. There's other things that are like, we need more education on this. We need more education on this
Oh, on
too.
everything. Yeah.
Yeah,
Right.
so I think it's just tough finding a balance because like this is a really major issue because since benzodiazepines are such a highly prescribed medication, then like it's okay. Well, maybe this is a little bit more focused right now, but I think just finding a way to find that balance, focus on what's necessary. And once again, I think it'll be a lot easier like once that research is really there, then we can just follow the guidelines, look those up really quick, and that's the exact information we need. So I think there's
Yeah.
definitely a lot that can be done to make things easier
Yeah.
on like us patients, everything.
Yeah. And the guidelines are being developed. The
Yeah.
FDA has put some money up, and
Mhm.
I'm on the patient panel for helping with
Mhm.
those. So fingers crossed they're good.
Yeah.
It's to be determined what we're going to come up with. The patients only
Yeah.
get so much say in it, but we're trying
Mhm.
really hard to influence and have a good outcome there. So
Yeah, that would
yeah,
definitely be a
everybody,
game changer.
yeah, stay tuned for guidelines. We'll see what they look like when they're available. I think it'll be another year or two before they're
Yeah,
done.
I think that's what I heard as well.
Yeah. So, well, Deja, thank you for chatting with me today and just joining forces with, the Benzodiazepine Alliance that you did work for. And now, I mean, it makes me feel comforted that, there's a soon to be pharmacist out there that knows what you know about these drugs, and you can go and educate others and sort of let them know, hey, if you know this about benzos and antidepressants and
Mhm.
psych meds, they all come with physical dependence risk and withdrawal and protracted injury, and
Yeah.
here's how to mitigate this, in your patients. So
Yeah,
it's
well,
awesome.
thank you for having me, and I will definitely be doing some more research into the non-benzo medications because that's something like I kind of heard of, but I didn't know too much about. So that's another way I can get into my wormhole of research again. So yeah, thank you for
Yeah,
that as
do.
well.
They're out there. The antidepressant withdrawal folks are out there, just like Benzo Buddies,
Mhm.
they have their own forums
Yeah.
and everything. So sometimes, that's one lesson I learned going through this as well, like having one foot in both worlds of being
Mhm.
a medical provider and a patient, is
Yeah.
that you can learn a lot from the patients who are experiencing it.
Yeah.
Just like, go hang out in their world and see like
Mhm.
what's happening in here, and they'll teach you,
Yeah,
So,
definitely.
yeah. Okay, well, thanks everybody for joining us today. If you haven't seen our film, Medicating Normal, and you want to, you can go to medicatingnormal.com/watch for the many ways you can watch it. Thanks again, Deja, for joining us, and everybody for watching, and we will see you soon. Okay? Take care. Bye-bye.